Welcome back to the Deep Dive. Today we're tackling a health topic that, well, it impacts millions worldwide. Dyslipidemia.
Mm-hmm.
You probably know it better as high cholesterol.
Right. And it's a major driver of heart disease, a huge one.
Absolutely. And heart disease is still, unfortunately, a leading cause of death globally. Now, the standard treatment, the go-to for most doctors, is statins.
And there's good reason for that. They have a really strong track record. Proven effective.
Yeah, definitely proven for reducing risk.
Oh, but...
And this is a pretty big but for a lot of people. Statins aren't always, let's say, the easiest path.
No, side effects can definitely be an issue. Or sometimes it's just personal preference looking for non-prescription options.
Exactly. And that's usually when people start digging into, natural alternatives.
That's where red yeast rice comes into the picture. You hear it mentioned constantly in conversations about managing cholesterol naturally.
Right. It has this long history in traditional use, centuries even.
It does. But for us, in this modern context, the real question is, what does the actual rigorous scientific research tell us? How effective is it, really? And importantly, how safe is it for improving those lipid profiles?
And that's exactly our mission for this deep dive. We've gathered a stack of research here, not just single studies, but these big systematic reviews, meta-analyses that pool data from lots of trials.
Yeah, comparing red yeast rice against placebos, against conventional drugs.
Right. The goal is to try and cut through some of the noise, maybe the marketing hype, and help you understand what the collective evidence actually suggests about using red yeast rice for dyslipidemia.
We're not here to give medical advice, obviously.
No, definitely not. It's about unpacking the findings, giving you the knowledge to have, more informed conversations, perhaps with your doctor.
And it's quite a bit of evidence we're sifting through. These aren't just small studies.
Yeah, tell us about the scale here.
Well, one of our main sources is actually an overview of systematic reviews. So it's like a review of the reviews.
Meta-analysis almost.
Kind of. That one source looked at 31 different systematic reviews. And those reviews, in turn, analyzed data from 165 individual randomized controlled trials.
What?
Yeah, involving almost 15,000 participants altogether. So we're really drawing from a broad synthesis of the existing research landscape.
Okay. Quite a foundation then. So let's start with the basics. Help us get oriented. What exactly is dyslipidemia and why is getting a handle on it so critical?
Okay. So put simply, dyslipidemia just means you have unhealthy levels of fats, lipids circulating in your blood.
Okay.
The main ones we usually talk about are total cholesterol, or TC. Then there's LDL-C, that's low-density lipoprotein cholesterol.
So the quote-unquote bad cholesterol.
Exactly. That's the one often labeled bad because it's the type that tends to build up as plaque in your arteries. Then you have triglycerides, another type of fat. And sometimes the issue is low levels of HDL-C.
High-density lipoprotein, the good one.
Yeah, considered good because it helps kind of ferry cholesterol away from the arteries. So dyslipidemia is an imbalance in any or all of those.
And it seems like doctors really focus in on that LDL-C number. Why is lowering LDL-C such a central focus in treatment?
Because the evidence is just overwhelming. High LDL-C is unequivocally identified as a major modifiable risk factor for what's called atherosclerotic cardiovascular disease, ASCVD.
Modifiable meaning you can actually do something about it.
Precisely. ASCVD is that underlying process, the slow buildup of plaque inside your artery walls. It narrows them, makes them stiff, and eventually that can lead to really serious events like heart attacks or strokes.
Which are, as you said, major causes of death.
Globally, yes. One of the sources we looked at, source 2, really underscores the impact. It cites data suggesting that hyperlipidemia, especially high total cholesterol, contributes to something like 4.4 million deaths worldwide every single year.
4.4 million. That's staggering.
It really is. So
Wow.
Treating dyslipidemia and specifically bringing down that LDL-C is just a fundamental strategy for reducing your risk of these potentially fatal events.
And the evidence showing that actually lowering the LDL-C number translates into fewer heart attacks and strokes, that's really solid science, isn't it?
Oh, incredibly solid. It's one of the most consistent findings in all of cardiovascular medicine. Source 4 mentions a huge meta-analysis. They pooled data from 26 different lipid-lowering trials. We're talking over 170,000 participants.
Wow.
And the conclusion was pretty compelling. For every 1 millimole drop in LDL-C, that's about 39 milli-GDL for those used to U.S. units, there was roughly a 1/5 reduction in the risk of major ASCVD events.
A 1/5 reduction. That's significant.
It is. And what's maybe even more striking from that analysis is this idea of lifetime exposure.
Lifetime exposure, what does that mean?
It means the data suggests that if you can achieve and, importantly, maintain lower LDL-C levels starting earlier in life, the long-term risk reduction is even greater.
So starting treatment sooner or maintaining healthy levels longer?
Exactly. It seems to provide maybe a threefold greater benefit compared to starting treatment later in life, even if you achieve the same LDL level eventually. It really drives home that managing LDL-C isn't just about hitting a number today, it's about reducing your cumulative risk over your entire lifespan.
Okay, so the goal is clear. Lower LDL-C to reduce long-term risk. And statins are the established first-line therapy. But, as we touched on, they come with challenges.
They absolutely do. Statins are remarkably effective, no question. Source 2 mentions one big review showing they can cut cardiovascular disease events by about 25%.
25%, yeah.
And reduce all-cause mortality by around 14%. They work, as we said, by targeting that cholesterol production pathway. But like any drug, they can have side effects.
Right. What are the main ones people report?
The most common ones you hear about are muscle issues, pain, soreness, weakness, sometimes called myalgia. Fatigue can be another one. Occasionally, you might see elevations in liver enzymes on blood tests, and there's also a small but documented increased risk of developing type 2 diabetes, especially, in people already predisposed to it. Source 2 points this out.
And for some patients, these aren't just like minor things. They can really impact daily life, can't they? Make it hard to stick with the medication.
That's a critical point. While lots of people tolerate statins just fine, statin intolerance is a very real issue clinicians see. Source 3 gives an estimate it might affect up to 10% of patients.
1 in 10, potentially.
Yeah, those estimates vary.
Right.
It's often lower in clinical trials because, well, trials tend to exclude people who might be prone to side effects beforehand. But for the individuals who experience truly debilitating muscle pain or severe fatigue or other significant issues, finding an alternative that still effectively manages their cardiovascular risk becomes essential.
And that brings us right back to red yeast rice. That's why there's so much interest in understanding the evidence for it.
Exactly. People are looking for effective options when the standard one doesn't work out for them.
All right, let's pivot then. Let's talk about red yeast rice itself. What exactly is this stuff? And crucially, what's in it that might explain these cholesterol-lowering effects people talk about?
Okay, so red yeast rice, or RYR, is actually a traditional Chinese dietary product. It's not something new. It's made by taking regular steamed rice and fermenting it with a specific type of mold, a yeast called Monaschis purpureus.
Monaschis purpureus.
Okay. And this fermentation process is what gives the rice its distinctive reddish-purple color. In fact, it's often used as a food coloring agent in Asia because of that color.
Interesting. So it's basically fermented rice. What are the active compounds in there that we care about for cholesterol?
Well, the fermentation produces a whole range of compounds, but the key players, the ones responsible for the lipid effects we're discussing, are a group of substances called monacolins.
Monacolins.
Okay. And within that group, there's one that's particularly significant for cholesterol lowering. That's monacolin K.
Monacolin K. Wait, that name rings a bell. A very loud bell in the context of cholesterol drugs.
It absolutely should, because this is the crucial connection. Monacolin K is chemically identical to the active ingredient in a prescription statin drug called lovastatin.
Identical. Not just similar, but the exact same molecule.
The exact same molecule. It's not an analog. It is lovastatin, just produced naturally through this fermentation process instead of synthesized in a lab.
Wow. Okay. So the active compound in this traditional fermented rice product is literally the same chemical as a pharmaceutical statin drug.
That is correct. And because it's the same molecule.
It works the same way.
Exactly. It works through the very same biological mechanism. Monacolin K, whether it's from RYR or from a lovastatin pill, inhibits an enzyme in the liver called HMG-CoA reductase.
HMG-CoA reductase.
Right. This enzyme is a key bottleneck, a rate-limiting step in your body's own internal cholesterol production line. By blocking this enzyme, both the drug lovastatin and the monacolin K found in red yeast rice reduce the amount of cholesterol your liver manufactures. Both Source 2 and Source 4 explicitly detail this identical mechanism.
Okay, that makes the biological basis really clear. But hang on. If it contains the exact same active molecule as a statin, is taking red yeast rice, basically just like taking a low dose of lovastatin, or maybe not so low dose, depending.
Now that is where things get much more complicated, and it's a super critical point that comes up repeatedly in the sources, especially source 3 and source 4.
Okay.
Red yeast rice is a natural product from fermentation. It's not like a pharmaceutical pill manufactured under strict controls to contain a precise, verified amount of one single active ingredient.
Right, it's made from yeast fermenting rice.
Exactly. And because of that, RYR supplements available on the market can vary wildly in their composition. Source 4 points this out very clearly. The actual amount of monacolin K in different RYR products can fluctuate enormously.
How much variation are we talking?
The range they cite is from as low as about 0.1 milligrams per daily dose.
Yep.
All the way up to maybe 14.5 milligrams per daily dose.
Whoa, wait. 0.1 to 14.5. That's more than 100-fold difference in the potential amount of the active statin-like compound.
It's a huge range. And remember, that's just monacolin K. The specific strain of that Monascus purpureus yeast used, the conditions it's grown under, how the rice is processed afterward, all these factors can influence not just the monacolin K level, but also the presence and amounts of other monacolins.
Like monacolin J and OEX you mentioned.
Right. And also all the other stuff naturally present in the fermented rice pigments, sterols, fatty acids, proteins, isoflavones. Source 4 lists quite a few. Some of those other monocolins might have a little bit of HMG-CoA reductase inhibiting activity too, but monacolin K is really considered the main driver of the cholesterol-lowering effect.
So it sounds like when you pick up a bottle labeled red yeast rice off the shelf, you might have absolutely no reliable way of knowing how much of that statin equivalent compound you're actually getting, or what else might be in there alongside it.
That's precisely the issue. This inherent variability in monacolin content is a major, major challenge. It makes it really difficult to compare results from different studies that use different RIR products.
Yeah, I can see that.
And it makes it really hard to apply the findings from a specific clinical trial to whatever product you might find in a store. It fundamentally means that not all red yeast rice is created equal. The effects seen in one study might not be replicated with a different product that has a different dose of monacolin K or a different mix of other compounds.
Okay, that variability seems like a massive elephant in the room for the research. But, okay, despite that challenge, let's dive into what the studies do show about effectiveness. How does red yeast rice actually impact those lipid levels, according to this body of evidence we're looking at?
Right. Let's start with the most basic comparison. How does RYR perform against a placebo, an inactive pill?
The baseline, yeah.
Source 2 conducted a meta-analysis specifically on this. They pooled data from 13 randomized trials that directly compared some form of RYR to a placebo. And what they found was that RYR did indeed significantly improve several of those key lipid markers.
Okay, good. So what kind of improvements did they see? Let's get into the numbers a bit.
Across those 13 trials, which included over 800 participants total, red yeast rice significantly reduced total cholesterol. The effect size they calculated was a weighted mean difference, or WMD, of NEMH 0.97 millimoles per liter.
Okay, megas 0.97 millimole. For people more used to MGDL, what's that roughly?
That translates to approximately a 37 milli-DLL drop in total cholesterol.
37 points. Okay, that's definitely noticeable.
Yeah. It also significantly lowered triglycerides. The WMD there was a 90.23 millimole.
Which is about?
Roughly equivalent to a 20 milli-GDL drop in triglycerides.
Okay.
And importantly, it significantly lowered LDLC, the bad cholesterol. The WMD was 90.87 millimole.
And in MGD?
That works out to a reduction of about 34 milli-GDL in LDLC.
Okay, so clear, statistically significant reductions in total cholesterol, triglycerides, and LDLC compared to taking nothing. What about the good cholesterol, HDLC? Did it give that a boost?
That same meta-analysis in Source 2 looked at HDLC as well. They did observe a small increase. The WMD was plus 0.08 millimole. However, this difference was not statistically significant when compared to the placebo group. The p-value was 0.11, which is above the usual threshold for significance.
Okay. So it seems like the main action is on lowering the TC, TG, and especially the LDLC. Raising HDL might be less consistent or maybe just a smaller effect.
That's what this particular meta-analysis suggests, yes. Compared to placebo, the impact seems much clearer on the bad lipids than on significantly raising the good HDL.
Okay, so RYR beats placebo on several key markers. But the big question then becomes, how does this affect size compared to the standard treatments like prescription statins or maybe other lipid-lowering agents?
Right, and that's where we need to look at the more complex types of analyses, particularly these network meta-analyses, like the ones discussed in Source 1 and Source 3.
Network meta-analysis. Remind us what that does again.
Sure, it's a statistical technique that allows researchers to compare multiple different treatments all within a single analytical framework. Even if you don't have direct head-to-head trials comparing every single treatment against every other one, the network analysis uses the available direct comparisons, like RYR versus placebo, statin versus placebo, maybe RYR versus statin, to make indirect comparisons across the entire network.
Sort of like building a web of evidence to see how everything relates.
Exactly. It lets you compare, say, RYR to a statin it was never directly tested against by using common comparators like placebo.
Okay. But that sounds like it could get really complicated, especially throwing in that product variability we just talked about.
It absolutely does. The variability in RYR preparations is a huge complicating factor when interpreting these network comparisons. But let's see what they found. Source 3 offered some insights based on their selection of what they deemed high-quality trials, and they found something quite interesting when comparing RYR alone versus statins alone.
Okay. What was it?
They actually found that RYR alone appeared to be more effective than statins, specifically at lowering triglycerides. The mean difference they reported was about negative 19.9 mg/L.
Wait, more effective than statins for triglycerides? That seems counterintuitive. I thought statins are the powerhouses.
For triglycerides specifically, that's what this analysis indicated, yeah. Now, for the other lipids, the picture was different. They found RYR to be comparable to statins for lowering LDL-C and also for elevating HDL-C.
Comparable. Okay, so similar ballpark for LDL and HDL.
But interestingly, for total cholesterol, RYR alone was found to be less effective than statins. The mean difference was about 12.2 milligdl higher TC when using RYR compared to statins.
Huh. So better for TGs, similar for LDL and HDL, but worse for TC, according to that analysis.
According to that specific analysis in Source 3, yes, it really highlights how the comparison can shift depending on which specific lipid marker you're focused on.
And Source 1, with its massive network analysis covering many more studies and specific RYR preparations, probably gets even more detailed and maybe complex.
Oh, definitely. Source 1's network included results for several specific named RYR preparations. Often you see codes like XZK, which is Zhao, or ZBT, Zibituo. These correspond to specific commercial products used in the trials conducted primarily in China.
Okay, so they're looking at branded RYR products.
Right. And their analysis really underscores that variability issue. For example, one comparison showed that XZK alone might actually result in higher LDL-C levels compared to atorvastatin and Lipitor alone. The mean difference was 0.56 millimoles, which is about 22 milladl higher.
Higher LDL with that specific RYR prep compared to a common statin.
In that specific comparison within the network, yes. But then another RYR preparation, ZBT, was found to decrease LDL-C levels compared to something called ethyl polyoleate, with a mean difference of NIDA's 0.52 millimole, about a 20 mg/dl reduction.
Okay.
And XZK, that first preparation, did show decreases in LDL-C when compared against other agents like Gemfibrozil, a fibrate drug, and ethyl polyoleate in other parts of the network analysis.
Wow. Okay, this is really reinforcing that point. Red yeast rice is not one single thing. Different formulations, different brands maybe, can behave quite differently when compared to other drugs.
Absolutely. You cannot generalize. The research is looking at the effects of specific products used in specific trials, often under specific conditions. It's not a blanket statement about any RYR supplement you might buy.
That's a critical takeaway. How did RYR stack up against other non-statin natural products or nutraceuticals in these comparisons?
Source 3 looked at this as well. In their analysis comparing RYR to other nutraceuticals, they didn't specify exactly which ones were in that group, they found that RYR came out significantly ahead.
How so?
It significantly reduced total cholesterol, with a mean difference of about negative 17.8 milligdl. It significantly reduced LDL-C, mean difference, negative 14.4 milligdl. And it also significantly elevated HDL-C compared to the other nutraceuticals, with a mean difference of plus 7.6 milligdl.
Okay, so compared to other supplements included in that analysis, RYR seemed to be a more potent lipid modulator.
That's what their findings suggest, yes. Within that category, based on the trials they analyzed, RYR appeared to have a stronger effect on improving the overall lipid profile.
What about using red yeast rice with other things, combination therapy? Did the research look into whether adding RYR could boost effects?
Yes, they did explore combinations, and this is another area where some interesting results popped up. Source 3 reported that when RYR was used in combination with other nutraceuticals, they observed what they described as a synergistic effect.
Synergistic, meaning the combined effect was greater than just adding the individual effects together, like 1 + 1 = more than 2.
That's the concept, yeah. The combination approach seemed to produce even larger reductions in lipids compared to just using the other nutraceutical by itself. The mean differences were quite substantial, about negative 31 mg/dL for TC, negative 28 mg/dL for LDLC, and negative 26 mg/dL for TG.
So combining it with other natural agents might amplify the benefits.
It appeared to in that analysis. Source One's big network analysis also dove into combinations, especially combinations involving that specific preparation, XEK, paired with conventional drugs or other interventions.
Right, you mentioned XEK earlier. What combinations did they look at?
Well, for instance, they looked at XEK plus atorvastatin, so combining that RYR prep with a standard statin.
An RYR product and a statin together. Interesting.
Yeah, and in certain statistical models they ran, this combination showed better results than using either XEK alone or atorvastatin alone. It lowered both total cholesterol and LDLC more effectively, and it also increased HDLC compared to either agent by itself.
So potentially additive or synergistic even with a statin?
Potentially, although it's worth noting that for the HDLC increase, some other statistical models in that same source didn't find a meaningful difference. So a bit of nuance there depending on the analysis method.
Okay. What other XEK combinations did they find?
They also saw that combining XEK with just basic health education interventions resulted in greater reductions in total cholesterol and triglycerides compared to using XEK by itself.
So lifestyle advice plus the supplement worked better. Makes sense.
It does. And importantly, they looked at specific patient groups. In patients who also had diabetes, combining XEK with their existing anti-diabetic medications led to better control of LDLC, TC, TG, and also boosted HDLC compared to just taking the anti-diabetic drugs alone.
Okay, so a potential add-on benefit for diabetics.
Seemed like it. And similarly, for patients who already had diagnosed coronary heart disease, CHD, combining XEK with their standard conventional CHD treatments improved the whole lipid panel LDL, TC, TG, HDL compared to just getting the conventional treatment alone.
It sounds like these combination strategies, particularly for people with existing conditions like diabetes or heart disease, could be a really promising area based on this data.
The analyses certainly point in that direction, suggesting potential added value, however. And there's always a however, it seems. Source One also highlights the complexity again. Even in combination, the specific comparison matters. For example, in those patients with coronary heart disease, while XCK plus conventional treatment was better than conventional treatment alone, it might actually result in higher LDLC levels compared to using atorvastatin plus conventional treatment.
So the RYR combo wasn't necessarily better than a statin combo in that case, for LDL specifically.
Exactly. It reinforces that you can't make blanket statements. The specific agents being combined and compared are critical. It's not a universal rule that RYR plus anything is always the superior option across all measures.
Okay, so let's try to quickly summarize this efficacy part. It seems clear RYR can lower lipids, especially LDL, TC, and TGs, compared to placebo. Its comparison to statins is mixed, maybe better for TGs in some analyses, comparable for LDL, HDL, maybe less effective for TC alone.
According to some sources, yes.
And combining RYR with other nutraceuticals or even conventional drugs often seems to enhance the effects, especially in high-risk patients.
The data suggests synergistic or additive benefits in many combinations, yeah.
But the massive caveat is the variability. The specific RYR product used in the trial matters hugely, and different products or combinations rank differently depending on exactly which lipid outcome you prioritize.
That's a perfect summary. And Source One really drove this home with their ranking analysis using SCRA scores. There wasn't one single winner across the board.
Right.
Different agents or combinations came out on top depending on if the goal was lowering LDL, raising HDL, lowering TC, or lowering TG. For LDL, things like Hypocol, another RYR product, and the XEK atorvastatin combo rank highly. But for triglycerides, Gemfibrozil, the fibrate drug, was top. It shows clinicians need to consider the patient's specific lipid profile and goals when weighing these options based on the evidence.
Okay, we've spent a lot of time on whether it works and how well. Now, let's turn to the absolutely critical other side of the coin, safety. Is red yeast rice safe to take? What did the sources say about side effects or adverse events?
This is obviously crucial, and the overall message coming from the sources is generally reassuring, at least based on the clinical trials reviewed. Source 2 and Source 4 both explicitly mention that RYR was generally well tolerated.
Well tolerated.
Adverse events were reported, of course, as they are in most trials, but Source 4 notes they were rarely described as being serious. And Source 3 went a step further, stating that in their analysis, RYR, whether used alone or in combination, did not appear to increase the overall risk of adverse events in people with hyperlipidemia compared to the control groups, placebo or other treatments.
Okay, so overall risk didn't seem elevated. What specific types of side effects were actually seen or reported in the studies, even if they weren't serious or more frequent overall?
The types of adverse events that did come up are somewhat similar to what you sometimes hear about with statins, though potentially less frequent, according to some analyses. We're talking about musculoskeletal symptoms, things like muscle aches, pain, myalgia, or weakness.
Okay, muscle issues.
Gastrointestinal reactions were also reported: stomach upset, maybe nausea, things like that. Hepatic issues, which usually means elevations in liver enzymes like AST and ALT found on blood tests.
Liver enzymes, right.
And then also things like fatigue and occasionally dizziness or headache. These categories pop up across pretty much all the main sources we looked at: Source 1, 2, 3, and 4.
Got it. So a similar spectrum of potential issues as statins, maybe. How did the safety profile of RYR compare directly to statins or other conventional drugs in these analyses? This is key for people considering alternatives due to side effects.
Right. This is where those comparative analyses, especially the network meta-analysis in Source 1, provide some potentially useful insights. Source 1's analysis suggested that some of the specific RYR preparations included in their network actually showed fewer side effects in certain categories compared to some of the other lipid-lowering drugs.
Fewer side effects, like which ones?
They specifically mentioned fewer muscular reactions, less liver dysfunction, and fewer gastrointestinal reactions with some RYR preps compared to agents like inositol, nicotinate, or certain statins. They even did those SUCRA rankings for safety outcomes.
Oh, ranking them by minimal side effects.
Exactly. For instance, for minimal muscular reactions, the top rank went to placebo, naturally. But second was ZBT, that specific RYR preparation, followed by rosuvastatin, Crestor, a potent statin. This suggests ZBT at least might have a relatively favorable muscle side effect profile compared to some other options.
Okay, so potentially a tangible benefit there, especially aligning with why someone might switch from a statin if they had muscle problems.
Potentially, yes. It hints at that possibility. But, again, we need to be careful with the details. Remember Source 2. The meta-analysis that looked only at RYR versus placebo. They specifically looked for data on muscle pain incidence, and they found that only 2 out of the 13 trials in their analysis actually reported that specific outcome. And based only on those 2 trials, they found no statistically significant difference in muscle pain between the RYR groups and the placebo groups.
So that specific analysis didn't confirm a difference from placebo for muscle pain based on limited data.
Right. It doesn't necessarily contradict the larger network finding from Source 1, which included many more indirect comparisons, but it does illustrate that the picture might not be universally clear-cut across every single analysis. The evidence on comparative muscle safety might be suggestive, but perhaps not entirely slam dunk.
Okay. What about the liver enzyme issue? You mentioned Source 2 said elevations were often mild or within normal limits.
Yes, Source 2 did note that. While Astol elevations were sometimes reported, they generally didn't seem to be clinically alarming in those placebo-controlled trials. Source 1's network analysis, looking across all the comparisons for liver dysfunction incidents, presented, well, a complex picture again.
So?
Some statistical models suggested that ZBT, that RYR prep, might cause less liver dysfunction compared to XCK, another RYR prep, and also compared to several statins and fibrates. That sounds good.
Yeah.
However, other statistical models run by the same researchers in the same source showed no meaningful difference in liver dysfunction when comparing ZBT to placebo or to XCK.
So even for liver effects, the answer kind of depends on how you slice the data statistically.
It seems that way. The comparisons are nuanced, maybe sensitive to the specific statistical approach used in the network meta-analysis. It's not a simple RYR is safer for the liver conclusion across the board.
Okay. Beyond these potential side effects of the monacolins themselves, is there any other major safety concern we absolutely need to discuss regarding red yeast rice, especially thinking about it being a natural fermented product?
Yes. Absolutely. And this is a critical one. It's not about the intended components of RYR, but about a potential contaminant.
A contaminant.
Yes. During the fermentation process with that Monascus purpuris yeast, if things aren't controlled properly, the yeast can also produce a toxic substance called citrinin. Source 4 specifically highlights this risk.
Citrinin, what does that do?
Citrinin is classified as a mycotoxin, a toxin produced by a mold or yeast, and it's known to be potentially nephrotoxic.
Nephrotoxic, meaning harmful to the kidneys.
Exactly, it can damage the kidneys. So this isn't a side effect of the monacolin K or the other beneficial compounds in RYR. It's a potential toxin that can be present if the manufacturing process isn't up to par.
So the safety risk isn't just about the active ingredient mimicking a statin, but about potentially getting a harmful contaminant alongside it if the quality control is poor.
That's precisely the concern. Source 4 really emphasizes that ensuring any RYR product is essentially free from significant levels of citrinin is paramount for safety. It puts a massive spotlight on the importance of the source of the RYR product and the quality control measures used by the manufacturer.
That is a hugely important piece of information for anyone even thinking about using these supplements. It's not just, does it lower my cholesterol, but also, is this specific product actually safe and free from this kidney toxin?
Absolutely. It adds a whole other layer to consider beyond just the clinical trial efficacy and side effect data for the intended ingredients. The sources also did briefly touch on safety in those combination studies for patients with diabetes or CHD. Generally, the safety profiles were assessed, and again, the comparisons to conventional treatments varied depending on the specifics.
Okay, so we've built this picture. RYR can affect lipid numbers. It might have a slightly better profile for some side effects compared to certain drugs, but that's variable and nuanced. And there's this crucial quality control issue with citrinin contamination risk. Now, let's talk about the very foundation all this evidence rests on. What did the researchers themselves say about the limitations of this body of work? How strong is the evidence, really?
Right. This part is absolutely vital for putting everything we've discussed into proper context. Understanding the limitations tells us how much certainty we can actually have in these findings. And Source 1, that big overview of systematic reviews, did a deep dive into this. They rigorously assessed the methodological quality, basically, how well those 31 systematic reviews were conducted, and looked for potential bias.
Okay, and what did they find about the quality of those reviews?
The findings were, well, pretty sobering, honestly. Using a standard tool called ROBIES, designed specifically to assess the risk of bias in systematic reviews, they concluded there was a high overall risk of bias in all 31 of the systematic reviews they included.
Wait, all 31? Every single review summarizing the evidence was judged to have a high risk of bias. That sounds like a really shaky foundation for drawing conclusions.
It's a very significant finding, yes. They didn't stop there. They also used another well-respected tool called AmStar2, which rates the overall confidence we can have in the results reported by a systematic review.
Okay, AmStar2, what did that show?
Using AmStar2, only one of the 31 reviews was rated as having moderate confidence. The other 30, that's nearly all of them, were rated as having low or critically low overall confidence.
Low or critically low confidence in 30 out of 31 reviews. Wow.
Yeah. It means that when experts systematically evaluated how these reviews were done, looking at things like how thoroughly they searched for relevant studies, how they assessed bias within the studies they included, how they dealt with differences between studies, heterogeneity, how completely they reported their methods and findings, they found substantial shortcomings.
Okay, can we unpack that a little? What does high risk of bias or low confidence in the review itself actually mean for us, trying to understand the science?
Think of it like this. A systematic review is supposed to be the gold standard, right? The most reliable form of evidence because it methodically gathers all the relevant studies and synthesizes them using strict procedures to minimize errors and bias.
Right.
If the review itself is flagged as having a high risk of bias or low confidence, it means the process used to create that summary was flawed. Maybe they didn't find all the important studies. Maybe they didn't properly account for weaknesses in the studies they did find. Maybe they combined results from studies that were too different. Essentially, it casts doubt on the reliability of the review's conclusions.
So we can't be assured that the results reported in those reviews, the numbers we were just discussing about efficacy and safety, are accurate or haven't been skewed somehow.
Exactly. It's like trying to take a high-resolution photograph, but your camera lens is smudged, maybe the focus isn't quite right, and perhaps you didn't even capture the whole scene. You get an image, but you can't be fully confident in its clarity or completeness. The methodological weaknesses in the reviews themselves raise concerns about the trustworthiness of their findings.
Okay, so the summaries of the trials have major question marks. What about the quality of the individual trials? The randomized controlled trials, the RCTs that went into those summaries, were they generally high quality?
That's another layer of concern. Source 1 noted that even within the individual RCTs included in those reviews, there were issues. Things like inadequate reporting on blinding meaning, where the participants and researchers truly unaware of who was getting the RYR versus the placebo or comparator drug. And just general completeness of reporting were flagged as areas needing more focus.
Blinding is pretty fundamental for avoiding bias in trials, isn't it?
It absolutely is. And Source 3, even though they specifically tried to select only high-quality RCTs for their analysis, they used a threshold score on a tool called the JDAD scale, still pointed out limitations. They noted that even among their selected trials, the reporting on crucial methodological details like how randomization was done, how allocation to groups was concealed, and the specific methods used for blinding wasn't always adequate.
So even the supposedly better trials had reporting gaps that could potentially hide bias.
It suggests that yes, even trials rated as higher quality weren't necessarily perfectly conducted or perfectly reported, which adds another layer of potential uncertainty to the findings derived from them.
And you mentioned heterogeneity earlier, the differences between the studies. How big of a deal was that?
It was consistently flagged as a significant limitation across multiple sources, including Source 1 and Source 2. As we discussed with the RYR product variability, the trials synthesized in these reviews were often quite different from each other.
How so?
They used different patient populations. They used wildly different doses of red yeast rice, as we know. The length of time participants were treated varied a lot. And critically, some studies used RYR alone, while others tested compound products that contained RYR plus other ingredients.
And that makes it hard to combine them statistically.
Very hard. When you have substantial heterogeneity like that, pooling the results together into a single average number in a meta-analysis can be statistically questionable, and the resulting average might not really represent the true effect of any specific intervention or apply well to any particular patient. It's like averaging apples and oranges and maybe some bananas thrown in the average fruit might not tell you much about any individual fruit.
Okay. And what about the outcomes that matter most to patients in the long run? Like, did these studies actually track whether people taking RYR had fewer heart attacks or strokes?
This is probably one of the most significant limitations highlighted, especially by Source 1. While the vast majority of studies tracked changes in lipid numbers, the LDL, TC, TG, HDL level.
Both surrogate markers.
Exactly. Very few trials actually reported on the hard clinical endpoints, the major adverse cardiovascular events, or MPE. These are the events we ultimately want to prevent: heart attack, stroke, death from cardiovascular causes.
How few trials reported on HC?
Source 1 found that out of the 165 individual RCTs included across all those systematic reviews, only 5 trials actually reported any data on ME outcomes. 5 out of 165.
Only 5. That's tiny.
It's very limited. And similarly, as we touched on before regarding lipoprotein or LPA, another important cardiovascular risk marker, only 3 trials reported data on LPA levels.
So the bottom line here seems to be, we have a fair amount of evidence, albeit from reviews with methodological weaknesses summarizing trials with potential issues and heterogeneity, showing that RYR can affect lipid numbers. But we have very, very little high-quality evidence telling us if taking RYR actually translates into preventing heart attacks, strokes, or death in the real world.
That is a very accurate summary of the situation described in these sources. Lowering LDL-C is strongly believed to reduce cardiovascular risk, based mainly on the massive evidence base from statin trials. We assume that if RYR lowers LDL-C, it should also reduce events. But the direct evidence from RYR trials demonstrating that reduction in hard clinical outcomes is largely missing or comes from a very small number of studies, often with their own limitations. It's a critical gap in the evidence needed to truly establish RYR's place in primary or secondary cardiovascular prevention.
Okay, so let's put all these limitations together now. We've got high risk of bias in almost all the systematic reviews, potential quality issues and reporting gaps in the original trials, significant heterogeneity making pooling results tricky, and a major lack of data on the clinical outcomes people care most about. What does this constellation of limitations mean for how we, and you, the listener, should interpret the findings we discussed earlier about RYR's effects?
It means we have to approach those findings with a healthy dose of caution. Significant caution, really. The evidence suggesting RYR can lower lipid markers is there, but its strength and certainty are considerably weakened by these underlying methodological issues.
So don't take the numbers at face value necessarily.
It means we should be wary of drawing overly strong or definitive conclusions, especially when comparing RYR's efficacy or safety directly against well-established therapies like statins, where the evidence base is generally much larger and of higher quality, particularly regarding clinical outcomes.
Right.
The observed effects on lipids are suggestive, yes, but we can't be as confident in the magnitude of those effects or their consistency across different products and populations as we would be if the evidence came from a stronger foundation. And the lack of outcome data means we simply don't know from this body of research if those lipid changes reliably translate into fewer heart attacks and strokes for people taking RYR.
Okay, that's a really important tempering of the earlier findings. So how do we connect all of this back to you, the listener? You might be someone grappling with high cholesterol, maybe considering different options. Why does navigating this complex, nuanced evidence matter?
Well, it matters fundamentally because managing your lipids is a cornerstone of protecting your cardiovascular health long term. That's the goal. And red yeast rice is out there, it is promoted, and it is considered by some people as a potential option.
Especially maybe for people with milder cholesterol issues or those who've run into trouble with statins.
Exactly. Maybe your numbers aren't high enough for a prescription yet, or maybe you're one of those individuals who genuinely experiences statin intolerance due to side effects. In those situations, exploring alternatives makes sense.
But as we've just spent a lot of time discussing, navigating the information about RYR isn't as simple as seeing a headline that says, "Natural remedy lowers cholesterol."
Not even close. What this deep dive into the sources really shows is the complexity. Yes, RYR can lower LDL-C, TC, and TGs. Yes, some analyses hint it might have a better side effect profile for some issues compared to some drugs, but we've also seen just how variable those findings are. The results depend heavily on which specific RYR product was studied, what it was compared against, which specific lipid marker we're talking about, and whether it was used alone or combined with something else.
So you absolutely cannot assume that any bottle labeled red yeast rice is going to give you the results reported in, say, a trial using the XCK preparation combined with atorvastatin, or that it will be truly comparable to your prescribed statin for preventing heart attack.
Precisely. And layered on top of that clinical trial evidence variability is the huge issue of the products themselves. That massive range in actual monacolin K content from almost none to quite a lot.
Yeah.
The unknown levels of other compounds and that really critical safety risk of potential citrin contamination if the manufacturing quality isn't rigorously controlled. All of this adds significant complexity to translating the research findings into a practical, real-world decision.
It sounds like the research, even with its limitations, doesn't point to a simple yes or no for RYR, but rather highlights a whole lot of "it depends."
That's a great way to put it. The findings aren't a blanket recommendation. As Source 1 concluded, the evidence is intended to inform clinicians with a reference for selecting the appropriate lipid-lowering agents based on the patient's condition and goals. It really emphasizes that considering red yeast rice shouldn't happen in a vacuum.
It needs to be part of a conversation.
Ideally, yes. An informed discussion, probably with your doctor or another qualified healthcare professional, where you can weigh your specific health situation, your lipid targets, the potential benefits suggested by the research, but also acknowledge the significant limitations, the product variability, the safety concerns like citrinin, and the lack of strong outcome data.
And it seems like choosing a specific RYR product, if you go down that path, requires an enormous amount of trust in the manufacturer, given that citrinin risk and the variability in the active ingredient.
It absolutely does. That potential for contamination with the kidney toxin means quality control isn't just a nice to have, it's essential. But unfortunately, as you know, the supplement industry often doesn't have the same rigorous oversight as pharmaceuticals.
Right, regulations vary and are often less strict.
So as a consumer, verifying the purity, the actual monacolin K content, and the absence of citrinin in a specific product you see on the shelf can be incredibly difficult, if not impossible sometimes. Some manufacturers might do third-party testing and make results available, but it's certainly not a universal requirement. This lack of standardization and readily available verification just adds another thick layer of uncertainty.
This has definitely been a deep dive filled with maybe more nuance and complexity than even we anticipated for what seems like a straightforward supplement on the surface.
It really demonstrates how scientific evidence works, doesn't it?
Yeah.
Especially when you're trying to synthesize research on complex natural products, dealing with studies of varying quality conducted across different decades and populations. It's rarely a simple yes or no answer.
It's much more about understanding those shades of gray.
Exactly. How well does it seem to work compared to what other options, in which specific groups of people? And maybe most importantly, with what level of confidence can we actually make those statements based on the quality and completeness of the underlying research? While also being honest about the limitations, like the huge gap in data on actual clinical outcomes.
That complexity is, yeah, it's challenging, but it's also incredibly important for anyone trying to make genuinely informed decisions about their health. And reflecting on all this, it leaves us with a really interesting and maybe slightly unsettling question to ponder. Given everything we've discussed, the substantial variability reported in the actual chemical composition of different red yeast rice products, the distinct outcomes observed in studies, depending on the specific preparation and the specific comparison being made, and that critical quality control issue regarding potential contaminants like citrinin. How much does the precise biochemical makeup and the verified purity of a particular red yeast rice supplement actually matter for its real-world effectiveness and safety? And perhaps more pragmatically, how can you, as someone considering this option, realistically navigate that profound uncertainty when faced with a shelf full of different products?
That's a powerful question. It really highlights the disconnect that can exist between broad research findings, even flawed ones, and the practical reality of individual decision-making in a marketplace with variable products and uneven regulation.
Absolutely. Something to think about. That's all the time we have for this deep dive. Thank you for joining us.